Good morning, everyone, and thank you for taking the time to come to this excellent conference. My congratulations to the team that organized this. They've put together a terrific program today, and I hope to do justice to the organizations that are present. I will tell you for sure, the PPSs that have organized this are amongst the leaders in New York State. The medical directors, the executive leadership have done a terrific job in really moving the needle forward for the populations that you serve. And in New York State, I think we are really very unique in the way we have approached DSRIP and Medicaid redesign in particular. There are 12 states that are going through this throughout the country, and no one has taken, which is not a great surprise being from New York, right? The depth or the challenge in such a robust and a meaningful way to try to impact the nearly 6 million patients who are receiving Medicaid throughout the state. So we really have kind of turned things upside down in many respects and looked for ways to make a sustainable challenge that we are undergoing now something that will continue on into the future. But I think one thing we need to reflect on, even with the change that we've made over these past 4 years, is that much of what we do is still very reactive, right? We plan care and we deliver care in ways that is always chasing after the bad things that have happened previously, instead of looking forward to try to understand how we can predict what will go wrong. And many of us who have been in the field look around us and say, I knew that was going to happen, or I knew this was going to happen, or I knew that was going to go wrong, I knew this other program wasn't going to really make it. And we have not taken the opportunity, and this is really what DSRIP is about, to transform some of those feelings and thoughts using the information and data analytics that are available to us to really stop being a day late and a dollar short and really start to impact the patients and our organizational structures in a way that can make the change that we want to make and allow us to apply the resources that are available to make this change. And we know everybody loves change, so everybody loves this idea of turning everything upside down and, challenging everything that we know as the premises of why we do our work the way we do it. But the truth is, when you see the impact that it has on patients and the caregivers, I think it is really worth going through the kind of the trials and tribulations that we are experiencing when we get to these places. This talk is a little bit backwards, which is something that I did by design. So we're going to go right to the outcomes part. Why would you 200 plus people be sitting here listening to me at all? So you really want to know, does whatever we do on Staten Island make a difference? And right now it's making a big difference. We've more than doubled the outcomes that we were supposed to achieve in 5 years by the end of year 3. So the behavioral health, emergency room utilization, medical utilization, and readmissions data decreased by 52 to 62% in the first 3 years of the program. So we're doing a lot, and it's impacting patients. And again, those of us who were in the field for a long time know the emergency room, unless you really need to be there, is not a place for anyone to spend time. The food is lousy, it's noisy, there are a lot of infections, germs, things go wrong there. And when patients don't belong in the emergency room, it's the worst place for them to be. So this kind of work is important. And readmissions certainly are expensive, costly. They give an indication that when somebody's coming back, what happened the first time didn't work very well. And this is really important work. We've also been able to earn somewhere in the neighborhood of $5 million a year in high performance funds. And this is important because that money is plowed back into our programs and our partners, and the ability to fund this work is extremely important. And I think one of the things that was very important for us was making sure that we got money into the hands of our partners immediately out of the gate. So any of organizations that really showed promise, we gave project implementation funds. Any organizations that had great ideas, we worked with them to make sure we could provide oversight and resources. And this is really, really important because people cannot do the work that they need to do without really being able to have some sense that the dollars are going to flow into their hands. And this is what we heard so many times throughout this trip, is that money was not happening. But I want to change gears here quickly and talk a little bit about a meeting that the Secretary of Health and Human Services held last week in Washington, and cover a couple of key points here. Structure does not guarantee outcome. You know, it's great to think that accountable care organizations, if you stand one up and you put it in place, there's going to be automatic change in terms of outcome, reduction of cost, improvement of patient care. The truth is, it really has not come to fruition, and there's a lot of reasons for that. The other is that ACOs that have taken two-sided risk, when you have skin in the game, people tend to get a little bit more serious about their outcomes, right? When you know you need to keep the lights on, you get a lot more creative, you burn the midnight oil, you work with your providers more closely, you take a little bit more risk, and those are the organizations that have shown the most promise. And I think the other piece that's extremely important here is that the empowerment of patients as consumers is something we really need to spend time on, and we're going to spend a little bit of time talking about that today, because what happens in a doctor's office is minutes out of a patient's life, especially those with chronic disease, and then their life happens when they leave. All the things that impact their health are things that in the past we have felt the health system had no responsibility for, but now we're realizing, well, we may not have responsibility for it. There are things that we need to do to try to engage people in a more longitudinal fashion in the health system so that they become an active player in changing their lifestyle choices, that we wrap around services and care coordination around them in a more effective way, and that we think of things that are more innovative to achieve those outcomes. But, you know, I think what he also said, patients also really need physicians to help them navigate the healthcare system. This is a really focal point that we need to continue to reorient ourselves about. It's not just about systems, it's about the personal relationship patients have with their practitioners, their doctors, their PAs, their NPs, and everybody else who is part of the system. Because that trusting relationship is where access starts, right? Access is not a function of bricks and mortar, it's a function of trust. And when people engage with those that they trust, the message is heard, but there is so much more we need to do to leverage that trust to make the change that we want to. And this is a slide that kind of illustrates what I'm getting at here. If you believe that clinical care impacts about 20% of a patient's healthcare outcomes, and all of these other things, their health behaviors, social and economic factors, the physical environment that they live in, are the things that really are driving so much of care outcomes, then we really do need to understand what is happening in a community, engage community-based organizations, engage policymakers, do things that are very important, because a perfect physician encounter does not guarantee a great clinical outcome. These are all the things that we need to work on, and this is why community-based organization involvement is extremely important, because these folks and organizations, such as community-based organizations, are really at the ground level. They're engaging people where they live, and they understand the challenges and barriers. But this talk really is about analytics, so let's talk about it in a little bit more detail. In the past, we were here. In the fee-for-service world, we talked about what happened, right? We looked at the past, we measured it, we commiserated over our failures, we celebrated our successes, but we really didn't move the dial a great deal. Where we're going is way out here, right? How do we predict what will happen based upon what we know, based upon those other variables that we talked about here, when we understand what a patient is facing, and how do we create programs that bring in all of that information and really make it unique to the patient encounter that we're working on. And that's what we've done on Staten Island. I don't want to get too theoretical here or philosophical. I'm going to show you real examples of how this works. I think this is really an important pictograph, if you will. The amount of money that is being spent in investment in health tech companies is enormous. And a lot of that focus is really going on in how patients engage in their own personal lifestyle choices, care coordination, and medical technology. This is where real money is going, because this is where change is happening. So we're going to talk about how VBP meets behavioral economics, some patient-facing tools, connecting patients and providers, and using incentives. Everybody loves the idea of gain sharing, especially if there's gain to be shared. But what about patients? What about their interest in the gain part of things? And I don't think it is unreasonable when we think about people selling patient data for millions and billions of dollars to different providers, that the patients also kind of be a little bit in the mix of the incentive side of things. I'm going to talk about a couple of apps that we're using that have proven very successful. And we don't have any financial interest in any of these things. We're using them as experimental tools to try to understand how they work, how they supplement the good work that the physicians, nurses, PAs, counselors, others are doing, but trying to understand and trying to see how this idea of behavioral change is so integral to what we're trying to achieve, because ultimately it's the person, not the disease, that we have to focus on. So one of these tools that we're using is something called Wealth. You may have read something about this recently. It's a very popular tool that is growing in utilization throughout the country. And it's a way, using behavioral economics, that patients substantiate their engagement and their compliance or adherence with a care plan as it relates to medication utilization, testing of some type of biological function, whatever it may be. And it's an evidence-based intervention where they use what everybody has in their pockets or in front of them right now, this, right? They take a picture of their medication in their hand. They take a picture of their glucometer reading. They send it in to the organization. And in interesting behavioral economic terms, they don't earn something, they avoid losing something. And that something is money, right? And it has proven to be much more successful in that model than earning. And it's a modest amount of money, I think $75 over 5 weeks. But amazingly, what this evidence shows is that after 5 weeks, the people who were most non-adherent, if they stick through the program to the end, become the most adherent. And the incentive stops. So the behavior change is like that period of time, that 5-week cycle, getting used to doing that thing that is important for them to do. And it works miraculously. We targeted 75 patients, and so far, 87% of them have had 90% or greater adherence in that group. These were the most non-adherent diabetic patients that we have seen in our program, the people that fail those DSRIP diabetic measures, right? This is a simple intervention. It's something that is really easily done, a modest amount of time being contributed. But what's also important about this is that very few patients drop out, and the information doesn't go just nowhere, right? If somebody shows that their blood sugar is 350 on that picture that they take, a call goes to their provider, and the provider can have a nurse, care coordinator, or someone call up and say, Joe, 350 is high, right? Is there something going on? Or if they miss 2 days in a row or 3 days in a row from sending in that daily communication, what's happening? Is there something we should know about? Do you want to stop in? Do you want to have somebody come out and see you? So again, this idea of engaging patients, behavioral change, and all of this is extremely important. Another tool that we're using with individuals in recovery is something called the CHESS platform. This is a tool that engages patients with their counselors. It's, again, something that's evidence-based. It was produced out of some literature that was created out of a university setting. And it really connects patients who are in recovery that we know drive excessive amounts of healthcare cost, certainly create for themselves and their loved ones a great deal of anxiety and concern in the community, often leading to overdose and sometimes death. In New York State and elsewhere, certainly in Staten Island, this is a real crisis. 2 years ago, we had the highest number of overdose deaths per capita in the 5 boroughs of New York City. And 2 years later, after the implementation of this and a number of other programs that we'll talk about, we went to the lowest per capita death rate related to overdose. So these kind of tools are really important. They're very unique. They engage the patient. They make the person think about the condition that they have in a way that they haven't thought about it before. It brings kind of a network around people so they don't think that they're on their own after they leave the confines of service. And we're also doing something with a company called Elazo Health that looks at adherence to medication control, right? Again, the idea of predictive analytics is extremely important. People that are not adherent to their medication regimen are likely those people in that slide that showed, Gartner's 4 quadrants, the people who are on the lower end of health, right? They're not adherent to care plans, and this puts in the hands of organizations the ability to reach out to individuals who are not adherent medication compliance and get them into the office sooner than when they show up to the emergency room. So again, these are not answers to everything, but they're little pieces of testing, of tools and theory about how we can make change and how that change can change outcomes. Another thing that we're doing, again, from the analytic and data exchange standpoint, is working with, from the standpoint of social determinant of health, our local Health and Human Service Agency. There are many people who are homeless, who have complicated lives, that lose their housing for reasons, and we know those people are often those who are non-adherent, have a lot of clinical and social, medical, and behavioral problems, but if they're not in a place where you can reach them, what do you do about that? We started a data exchange program with HRA, and twice a month we compare rosters with each other. And we find out who on our roster is in shelter housing. And we have community-based organization and partners reach out to these individuals. We reach out to the providers of care using our state claims data to identify who treated these individuals last, and we try to get them into stable housing. So we have a partner working with HRA to do stable housing, and we have community-based organizations reaching out into the shelters to provide real care coordination and connect them back to care. Again, not any of these things are total solutions, but they're testing different approaches so that we understand what works, where to invest our resources, and where to engage individuals so that we can move the dial on outcomes. But there are a lot of fundamental information exchange barriers, and these are things certainly that complicate our life because we see a lot of data in front of us. And unfortunately, many times we don't feel as if we can do anything with it because we don't want to run afoul of OHIP, the Data Security Division, individuals whose names shall remain unstated. But there are ways to overcome these challenges, but certainly legal requirements for consent are rooted in a paper record era, right? The things that were written 40 years ago were not contemplating electronic health record, the internet, data exchange, engaging partners across a continuum, certainly weren't contemplating DSHRP and the engagement of partners throughout communities. These are things that need to be overcome. The fact that we don't have a standardized EHR format, it's great for the people that create electronic health records, not so good for patients, not so good for providers. It leads to a lot of cost and complexity. Many of the plans that we work with are not interested or reluctant to share data for a lot of different reasons, many related to legal requirements, many for other reasons. And there's generally an industry failure to appreciate the need for a socialized record to achieve the outcomes that we want to achieve. So these are things that we have overcome in many respects, and we're going to spend some time talking about them right now. Again, these challenges, everybody understands very much. We talked about social determinant and access, the demographics of the population. And the payment model, certainly, that we've labored under for many years, is not incentivized to produce outcomes, except now, and really the focus of this conference, when we get into the value-based purchasing world, when we get into the risk-sharing world, the things that we need to do now are quite different than keeping the waiting room full of patients and seeing more and more and more patients, and much more focus on understanding how do we longitudinally impact the care of the patients that we're working on and reduce excessive utilization and focus on what really works. So the idea really is to turn this data into business intelligence, right? You want to have a big absorption and ingestion of data from every source that's possible and try to be able to use that data to understand how do you invest in the resources that are going to make a difference, what resources and programs are making a difference, and try to create solutions from these multiple data sources so that you can win in the value-based purchasing era. And it's a little bit of a different data model in the value-based purchasing world, right? You need to be able to have this and connect all the patients that are engaged with your organizations and look at the things that really can help you turn the dial. Understanding care gaps, the interoperability is critical between the RHIOs. RHIOs are great, but they are an unfulfilled promise, honestly, at this time. They ingest millions and millions of patients' records, and very little in the way of records are shared with the providers. This is a major challenge and something we really need to work on. And understanding what is working in your organization in real time is critically important, right? You can't look back at 3 months, 6 months, 9 months, 12 months ago, or get the claims data from 9 months ago and say, what we're doing now is working. How do you pivot off that? How do you change resources? These are things you really need to be able to understand. And we've done it by deploying a very sophisticated analytic platform that ingests information from multiple sources and putting dashboards in the hands of our providers, putting a portal view of our providers so they can look at their patients' performance, and really using a lot of hotspotting and geo-mapping to really figure out what is going on by condition in particular regions, by providers, and really focusing on those deltas. Who are the people that are extremely successful? Let them work with the individuals that are not so successful and try to socialize this idea of success. And this is really what's so important. Our CIO is not here, so I'm not going to spend a lot of time on this unless Mark Bryant wants to help me out. Our partners from Spectrum Medics are here, and they have helped us stand up the cloud resource very early on and doing a lot of the measurement work with us. But the idea is, if you think about this array of data that's available, if you look yourself and understand, well, the only thing that's really coming into me is claims data. I get some electronic health record data from my partners. It's not enough. There is just simply too much information that can lead to program development and outcome monitoring and understanding where adherence and investment needs to occur. And the plans are really important. You have a great plan in the upstate region here. I guess I could say the name. The Capital District Health Plan is terrific, very well received in the community that they serve for a lot of different reasons. These are the organizations that are forward-thinking and can make a difference. But working with, there are certain plans, I guess there's one in particular, it's in every county, that is not necessarily the most supportive of this kind of change. For whatever reason, I can't begin to tell you, right? When we reduce utilization, they economically benefit. When we provide better care to patients, the patients improve. You would think that they would be all over the kind of change we're trying to make. It's really not happening. But the idea is to use this information into program development, right? It's not just about the theoretical approach or academic approach to using data. It's about trying to understand how you can fashion things that work. And often they're very different from what we have in place now. People did their best to create programs based upon their economic understanding, their organizational investment in capital, in people, in technology. And oftentimes when we look at the outcomes of that kind of investment, we say, we would never do those things now, knowing what we know now. But when so much has been put, if you will, on the table already, they inordinately try to make things work that are not set up to succeed. But looking at data, using it to create programs that work by ingesting information from multiple sources and really focusing on the things that we talked about is extremely, extremely important. This slide has an enormous amount of information on it, but really what it's intended to illustrate is if you want to be successful, you really need to spend a lot of time in the behavioral health space. If you don't, you lost. I can tell you right now. The impact of those individuals, and probably 45% of the patients that we serve have behavioral health primary or secondary conditions, drives 50% of excess utilization. This is an incredible amount of burden of disease in the community, and patients are not getting the care that they need. This is really the point, and it's a lost resource, right? So you need to work on everything from stigma, which is social type of things, to engaging every partner that you have and put them in a place to be successful. And especially in the behavioral setting, many of the organizations you're going to work with are behavioral health, community-based organizations. Many of them don't provide billable services to Medicaid, but they are the ones that patients engage with because they have the lowest access threshold. And if you can make good partners with them, you can really make a lot of success. And the other thing, of course, is extremely important, and at the core of just about everything we do, is making sure that everything comes back to primary care providers. If that does not happen, again, you lose. Because the relationships with primary care providers drives a lot of the trajectory of service, the care coordination, the work that happens with the patients that you serve, and whether it's promoting PCMH, integrative care, which really is the future, right? Behavioral and medical, medical and behavioral, none of this can work unless we connect all the dots. And the social determinant of health and public health data really does define for us many of the programs that we've created, and we're going to talk about those now. But there are dozens of organizations we work with that connect with other partners in ways that really kind of drive the change that we're trying to make. Some of these are clinical providers, some are health systems, some are substance abuse providers, some are community-based organizations that provide no clinical service whatsoever, except access to patients to have the lowest threshold of barrier to engage the next level of partner. So this is a little bit about if we were in the live data warehouse right now, we'd be able to search and filter on any medical condition that we provide service to a patient on, and filter that by their age, sex, or race. It allows us really to identify where are concentrations of conditions that we need to apply resources to, and if we hovered over any one of those particular patients, and these boxes are an illustration of what that would look like, we see 3 years of their claims history. So we see a trajectory of service over time and understand if they are part of programs that we've created, are we making an impact or not? This is a very powerful tool. It allows our providers to work together, to come up with thoughts, strategies, ideas, and then prove them out, right? It's great to have a unique and creative idea. It's much better to understand if it's going to work, because the resources are not infinite, and we need to see if things are working, and we really need to understand if we're investing in a particular condition. In this case, I believe it's a behavioral health patients who have asthma. The concentration of the condition is in the North Shore of our community. We're not going to go invest resources where there's a scattered smattering of service. We'll reach out to those patients and their primary care providers. But if we're going to create program around a condition or a subcondition, we want to go where the action is. Or if you're a fisherman, you don't go fishing where there's no fish. Another thing that drove a lot of our change, especially in the behavioral health setting and working with the local governmental authorities, was looking at EMS data. EMS data is extremely rich. It really tells you things that you could never appreciate from looking at a paid claim. And when we started drilling into our EMS data, we saw enormous opportunity to work in the behavioral health space for individuals who have alcohol and substance abuse and try to continually dial that back. Who are those people that have the highest utilization, and drill into their history? Where do they live? Who do they see? Who do they not see? Are they adherent? Are they non-adherent? And what are the locations where these things are happening, so that we can target service in those particular areas? This is gold, right? There is no way you can be successful, and it's especially important, I think, in a region like this, where your geography is way more complicated than ours, right? You have a vast spread over multiple counties. Trying to understand what is happening in regions, locations, communities, boroughs, zip codes really allows you to get very targeted about who to work with, what to apply in terms of resources, where do you stand up services for patients, where do you put in resource centers, where do you put in 24/7 recovery locations. All of these things are critically important. You can't do it by guessing. This is business intelligence at its essence, and it helped us drive a lot of change. We're working with EMS now. When we analyze this data, 5% of callers use 45% of EMS calls on Staten Island. 10 times what you would expect in one small cohort. Not good news if you have a heart attack, a stroke, been hit by a car, been victim of some violence, because every non-emergency call delays response time. Working with EMS and the NYPD has been an experience, one I'd not necessarily like to repeat. But we're making change, and we did finally implement, after about 14 months of conversation that really could have been cut down to about 3 weeks, a program where 911 callers who present with certain conditions that we identified through the analytics are sent to an LCSW instead of having an ambulance deployed. And it's having a big impact. The other thing that we saw from that data is that individuals with substance abuse disorder go to the emergency room an enormous amount of times. Then we started bringing in overdose data from the ambulances and from the NYPD, and we found that individuals who overdose don't overdose just once unless they die. They overdose over and over and over again. We also understood from working in the workforce space that on Staten Island, there were 2 peer recovery specialists as it relates to substance abuse. There are 500,000 people on Staten Island. There are about 20,000 visits to the emergency room related to overdose. The numbers did not add up at all. We engaged with a community-based organization. We put about 30 individuals through scholarship training to become certified peer recovery coaches, put them in the emergency rooms, in 24/7 resource and recovery centers, and it has had an enormous impact and reduction. And that's how, when you get back to those first couple of outcome slides that I showed you, you make that kind of difference. Because people speak to a peer, that individual has walked a mile in their shoes. And believe me, it's much more valuable at the initiation and engagement of an individual than speaking to a physician or a nurse. They need the doctor, they need the nurse, they need the counselor, but that access barrier needs to be next to zero. And that's what the peer recovery coaches are doing. And it has had a tremendous impact, and it's a very small investment. The scholarship money for the 30 peers is less than $20,000. I mean, who's not going to make that investment every week? And if you look at the utilization that it's reduced, the lives that it's saved, it's an enormous benefit, and these are very fundamental things. You have a program in this region that is very similar to the HOPE program on Staten Island. It's a post-arrest pre-arraignment program where individuals arrested on low-level drug charges. We put the peers in working with the district attorney. We put the peers in the 24/7 recovery center that the individuals can go right to after that release from the precincts. And again, an enormous impact, very positive. Over 600 people in the last 18 months have gone through the program. The recidivism rate is very low, less than 15%. This is the kind of thing, again, low investment, high impact. This is where you want to put your bets. And this is the one-year implementation results of the peer program working in the emergency rooms. Again, enormous impact. And the beautiful thing is, many of these people go on to become peer recovery coaches. And from the workforce component, again, what we did is we have paid the salary for 3 months for many of these folks when they graduate from programs. So community-based organizations that are a little reluctant to bring them on because they're not so sure if they can economically afford them, kind of have a glide path to see how this will work. And it has had a great impact on them and on these individuals. In fact, we worked with one of the local hospitals and our union, the 1199 union, and peer recovery coach is now a covered program in 1199. So these were people who had very likelihood of employment, housing, getting back their life back on track, who are now union members, earning salary with benefits, turning their life around, and becoming kind of that beacon of hope to others who are out there. This is a good news story. The other thing, again, in the behavioral health space that we've done by working through this program and others is more than quadruple the number of people coming into medication-assisted treatment. District year 1, 300, 650 in year 2. District year 3, nearly 1,200. This is the greatest evidence-based recovery method that we're aware of, and it has an enormous impact on patients overdosing, avoiding overdose, and look at that. For every individual in that group, the over 2,000 patients, a 52% reduction in their ED utilization. And those ED utilizations, half of them were related to overdose. This is a letter I sent out to some of my PPS lead colleagues just a little while ago. And it was signed off by Rob Kent and myself. And it is, I consider, a milestone. It is a universal consent form that allows individuals who are in recovery, who have 42 CFR covered diagnosis, to share their information with the RHIO and have that information shared with every provider that they see. This has been an enormous barrier to service, right? Not understanding what the next person and the next person and the next person does for an individual who needs the most help of anybody has been an incredible waste of resources, placed patients' lives at risk for no reason, or as I like to say when I get thrown out of the education department talking to them about asthma, I'm sure the families of those little children who die from an asthma attack leave the funeral home saying to themselves, I'm glad their privacy was intact when they died. It does not make me a favorite there. But this is the kind of steps that we need to take. Exchanging data, exchanging information, looking at the things that are going to make an impact are very important. And these are some other conditions that we've tracked. It's not just about behavioral health. Going back to that map and looking at concentrations of care, where services need to be provided. We've looked at conditions throughout our community, understand where they need to be focused on. We also bring in a lot of social determinant, other variables like the country of origin, because everybody does not take information that is given in a kind of vanilla way, right? If they have a certain cultural barrier to accepting information, you need to understand what that is. And we funded a number of programs, right? The Stanford model for chronic disease self-management, again, that uses peers. Addressing food deserts, looking at small physician practices that were not necessarily our partners when we started, and realizing, looking at the data, that small practices often don't have the bandwidth to do the kind of work that they need to do in terms of care coordination, using that tool like Wealth and other things to manage patients with diabetes and other conditions, and bringing them in, providing funds to them, providing technology support, getting our practitioners in their offices to provide service and get these kind of programs available. One unique thing we started to do with some of the FQHCs was have them write a food prescription. So somebody could go to a location and pick up free, fresh fruits and vegetables. Very simple, low threshold, low cost, and huge impact. Same thing with asthma. You know, where is asthma most concentrated? What do we do about it? What is missing? We had the providers come in and say, you know, Joe, I do great asthma care in my office. And then the person goes home. I don't know what's going on in their home. Right? What are the triggers? What are the things that need to be managed? And these are things that really are important. Again, that 10 or 15 minutes the individual spends with the doctor or the pulmonologist or the nurse is not the same thing as somebody going into their home and understanding that there is mold, they're using pesticide that is triggering asthma, there is smoking, there's all kinds of things going on in the home, and try to impact some of those things. And we're working with multiple community-based partners. In New York City, there's a number of programs that have been funded to go in and do remediation of some of these issues. Again, low cost, right? If you give somebody hypoallergenic sheets and reduce a $750 emergency room visit, that $15 has a 50-time return. I mean, that's good money. The substance abuse we talked about, again, we went from the highest per capita mortality rate to the lowest in 2 years, and a lot of it has to do with all those programs we were talking about. You know, behavioral health collaboratives have sprung up throughout New York State. Many of them are naive when it comes to data management, and we are working with them closely in our region and some others to talk about how we can support them with some analytic services that, again, do that same kind of approach. Look at the geomapping, illustrations of where their concentration of patients that need to be managed are, what services are they missing, where's gaps in care, what the trajectory of those services is. Again, you need to understand at a very granular basis where to put your resources to make improvement, right? If you're doing well here, put your resources there. If you're doing well here, put your resources there. You need to be able to manage the data on a patient level. It's not simply sufficient to say it's 80%, it's 70%, it's 65%. You really need to be able to drill these down, and drilling into any one of these bars, list that whole group, the whole universe of patients that you're working with, and the providers they're working with, and the conditions that they're working with. And this really is extremely important. So, closing thoughts, I think I'm doing well with time. Everybody loves gain sharing, especially if there's gain to be shared, and in value-based purchasing, it's not so clear that the gain is going to be there unless you really are presenting a very sophisticated approach to managing the population that you have in front of you. Managed care contracting is not art, it's science. If you work with a plan, present company excluded, you really need to have the information in front of you. I liken it to going to a casino, having the cards in front of you, the dealer has a mirror in back of you, he sees your cards, he sees his cards, he knows when you have 20 and he has 14, and he folds, and you really need to have this kind of information, granular, aggregated, and understand where you can make a difference and work with the plans. The plans really do have the same goals as we do in many respects, but they have different drivers. So we really need to find a common ground. As I said, VBP really demands predictive strategic planning with big data, and that big data really means looking at the whole universe of information around the patient. Their housing, their employment, their economics, all of these things are extremely important. You can't just look at those isolated clinical contacts and think that you can make predictions about utilization of service over time. You'll be wrong every time. You could read the rest of these. As I said, social determinant of health information is extremely important. And probably the last bullet is one that really is a super take-home message. You need to empower your partners. You work with a lot of different people, a lot of different organizations. Putting them in a place to be successful will allow you to be successful, will improve the care of your patients and the community that we serve. Thank you so much for your time.